Hello and welcome to my presentation. I'm Dr. Becky Lynn. I'm the director of the Center for Sexual Health at St. Louis University in St. Louis. And I'll be talking today about managing HSDD in women with cancer. I'm going to give you a practical approach. These are my disclosures. So I approach this from quite a unique perspective. I am an obstetrician gynecologist, but I'm also a cancer patient. So I have been on both ends of the spectrum here when it comes to dealing with cancer and problems. So first, I'm going to run through the definition of HSDD, which, as you know, is Hypoactive Sexual Desire Disorder. I'll go through some of the contributors to it, and then I will discuss my paradigm for treatment and how I approach the typical problems that women with cancer face. So we'll start with HSDD. I know you all know what HSDD is, but I'm just going to give you the basic definition again, just to remember. It's a lack of motivation for sexual activity that's been going on for greater than 6 months. It can also be reduced or absent spontaneous desire, reduced or absent responsive desire to erotic cues, or basically a loss of desire to initiate or participate in sexual activity. And the most important part of this definition is that it causes personal distress. If someone has low sex drive, hypoactive sexual desire, and they're not bothered by it, then we can't really call it a disorder. It's really that personal distress that defines it. But nobody comes to my office saying I feel personally distressed because I don't respond to erotic cues. Most of my patients will come in and say, I just don't feel like having sex anymore. Or I hear often, I want to have sex again. And actually, the terminology has changed. In the DSM V, we call this low desire hypoactive sexual desire disorder. And we now have the DSM V, where low desire has been combined with arousal disorder into female sexual interest arousal disorder. But today, we're really going to focus on the desire side, HSDD. So the magnitude of the problem, it's big. This is, in general, 40% of women in this study. This is a pretty famous study. The Preside study were found to have low libido, and 10% of women were bothered by it. They were distressed by it. So if you're a practitioner and you see 20 patients in a day, there's a good chance several of those patients will have low desire. And if we don't ask about it, we won't be able to treat it. And it's a really important topic for many, many women. And there are so many things that lead to low desire, and not just lead to it, they contribute to it. In my practice, there's usually not just one thing that's causing low desire. There's physiologic issues like cancer, neurologic problems, cardiovascular disease, pain, medications are a big one. Many patients are on SSRIs, those are Prozac, Zoloft, Paxil, things like that. Then psychological things matter a lot to HSDD. Depression and anxiety are what I see in my practice. But also prior sexual or physical abuse, stressors. You know, libido seems to be the first thing to go for a woman when she's stressed. Then there's problems in the relationships that play a role, and that's something that's really important to ask about, or lack of privacy. Or partner performance and technique. And then the sociocultural influences, inadequate education, conflict with personal values. So many things play a role. It's never just one thing that's contributing to HSDD. The good news is cancer patients are surviving. Over time, with modern medicine, more and more people will make it through cancer and become survivors. So the cancer community has turned more towards looking at quality of life issues. There's a lot of research going on about quality of life. And by 2024, there will be almost 19 million cancer survivors. So we owe it to our patients to talk about this, to address it, and treat it. So what happens when a patient is diagnosed with cancer? Your world is turned upside down completely. All it takes is that one sentence, you have cancer, and everything in your life is what things were like before the diagnosis and what things are like after the diagnosis. And you get that diagnosis, and then immediately it's all about treatment. Got to beat the cancer, got to be a survivor, get it taken care of, whatever it takes, get rid of the cancer. And that's the whole cancer experience that a patient will go through, whether it's chemotherapy or surgery or radiation. But then after that comes cancer survival and getting on with your life. And that's where treating HSDD comes in. And sexual dysfunction is common in cancer patients. So when you look at the numbers in the Preside study that I had mentioned, patients with cancer tend to have a higher percentage, or they tend to have sexual problems a higher percentage of the time. I focus in my talk a little bit more on breast cancer because this is a very large player in terms of sexual dysfunction, only because women with breast cancer, their sexual organs are affected, and then they also, the majority of the treatments work to affect their hormones or lower their estrogen levels, or chemotherapy puts them into the menopause, and that really affects sex drive. It's your ovaries that contribute to sex drive. They're not the only thing, but they play a big role with the testosterone that ovaries make. And then I'll also talk a little bit about gynecologic cancer because this is another one that affects the pelvic region. It affects blood flow to the vagina and the vulva and the clitoris. So women with cancer in general have a higher chance of having sexual dysfunction than if you look at all comers. And sexuality is important to cancer survivors, regardless of cancer type. So in 2010, Livestrong did a survey, and they found that sexual function ranked as the third most common concern for cancer survivors. So patients may not always bring this up. It's embarrassing to talk about, but it's really important to address. And the other issue is that the cancer treatment itself causes a lot of sequelae that affect sexuality. So if you think about mastectomy, or all of a sudden you have a colostomy, well, that's not very sexy, doesn't put you in the mood when you have stool connected to your abdomen. Or you've had a vulvectomy, that can be incredibly embarrassing. You don't feel sexy anymore when you've got a lot of scarring in that region. And then chemotherapy also wreaks havoc on sex. You're tired all the time. You may lose your hair. You become menopausal, which can lead to vaginal dryness and painful intercourse. You may have diarrhea or feel nauseated. And radiation contributes as well, with skin thickening, burns on your chest, or the concern by the patient or her partner, am I radioactive? And then those post-treatment medications play a huge role, especially the hormonal modulators that we see used in women with estrogen receptor positive breast cancer. So things like tamoxifen and the aromatase inhibitors really lower the estrogen levels that the tissues see. And then, of course, the antidepressants, the SSRIs. But really, when you talk about desire, you can't just talk about desire. Desire has everything to do with pain, arousal, orgasm. It's hard to just pull one thing out. If you have painful sex, your desire is going to go down. If you can't reach orgasm, your desire is going to go down. It's hard to just look at it just desire. There's so many things that play a role. So when we talk about improving desire or creating a paradigm to treat cancer patients with HSDD, you really have to address the entire sexual experience. So how do I address this? What's my paradigm? We'll talk about treatments. So in a cancer patient, you want to treat what is fixable and accept what is not. So if somebody's had a mastectomy, they may no longer have breasts, and the scars tend to be numb. And many times, many patients will tell me that nobody discussed this with them. They mourn their lost breasts. They don't have nipples, no sensation there. And that's not something that I focus on, we say, okay, we accept that. What can we do? You can have reconstruction or wear a sexy bra. You can approach it that way. But there are other things in the whole paradigm that are fixable. So you really have to look to what else can you tune up. So I approach it by looking at these three things: ask, reassure, and educate. So I first ask about it. Incredibly important. Make sure you ask your cancer patients. And what I do is I use the NCCN Questionnaire. This comes from the National Comprehensive Cancer Network, and it's 4 simple questions. So this won't add a lot of time by giving somebody a long and detailed questionnaire. Won't add a lot of time to your visit. It's very straightforward. The patient can answer, and then it's more discreet. They don't have to say the word. They don't have to talk about it out loud where they might be embarrassed or they might think that something is truly wrong with them. And sometimes cancer patients and survivors don't know that the symptoms that they're having are related to their cancer treatment. So they're concerned that something's terribly wrong and they might not bring it up. So this is super easy, 4 questions only. And then as the provider, you can then bring it up yourself once you know that they're looking for help. In my institution, our oncologists also give out this questionnaire because oncologists in general, not all oncologists, tend to be not as well-versed in approaching sexual problems. So this makes it easy for the provider to ask about it as well. And then breast cancer patients and cancer patients in general might also say to themselves, well, should I be worried about sex when I should just be grateful to be alive? And the answer is absolutely yes. Sex is an important part of overall well-being. It's a human right. So we don't want to brush it under the rug. Oh, you should just be grateful that you're still here and not worry about it. It's important. When I educate patients, and I educate everybody, cancer survivors and patients without cancer, I want to make sure that they understand where desire comes from. I talk a lot about arousal before desire, how many times in women, desire comes secondary. It comes after arousal. So maybe a woman gets a hug, a kiss, or something that she needs, and that creates the desire, as opposed to a spontaneous sexual thought. And I explain how normal that is, that that's normal and that's okay. Many women are not the initiators. I talk about the importance of nurturing your relationship, making it a priority, and communication. And sometimes cancer treatment and being a cancer survivor really force couples to communicate better because things are different post-treatment and things have changed, and now you really need to open those channels of communication and discuss it. I will recommend erotic reading. Just to retrain your brain to have sexual thoughts. The brain has neuroplasticity, and if your mind hasn't been focused on sex, it's been focused on the diagnosis and the treatment, it's a little out of shape. So I do recommend erotic reading, and I might say read for 10 minutes at night, 3 times a week, or you can read with your partner. And in a similar fashion, visual stimulation helps as well. So look at a magazine, look at something sexual, and sometimes that's all you need to get to that natural desire. In my cancer patients, especially in survivors, I encourage a healthy lifestyle, although everyone should lead a healthy lifestyle. I encourage physical activity. So aerobic exercise has been shown to improve libido in both men and women. So that has many other benefits to it as well, but as far as sex drive, it's also a positive benefit. I encourage a healthy weight. You want to have a good body image of yourself. Body image is very important. And after a cancer survivor has undergone some surgery, that body image, which plays a big role in your sex drive, may be affected. So you want to maximize what you can and maintain a healthy weight and a healthy diet. You also want to get adequate sleep so you're not fatigued. And then I like yoga. I recommend yoga a lot to keep a healthy pelvis, maintain the pelvic floor, but also for strength, flexibility, and relaxation. And yoga also helps with anxiety. And during cancer treatment, and usually the first couple years, depending, after the treatment's over, cancer survivors tend to have a fair amount of anxiety because they're worried that their cancer is going to come back. But specifically, to focus on the cancer patients, I ask my cancer patients and survivors to find your new normal. This is a phrase that is commonly used in the cancer community, and I personally love this phrase. You've got to find your new normal. It's not going to be the same as it was before you were diagnosed, before your treatment, but it doesn't mean that it can't be satisfying again. The other thing I address is recommending that you be pleasure-focused instead of goal-focused. Enjoy every minute of sex play. Sex isn't always about reaching orgasm. It's about closeness and touching and being together. So you kind of have to reframe the whole sexual experience and find your new normal. When it comes to breast cancer, I want to point out how much breast cancer treatments affect women's sexual self-esteem. If you think about what happens to a woman when she's diagnosed with breast cancer, she has a mastectomy, like I mentioned before. Now you have missing parts. You might be embarrassed about what your chest looks like, or a lumpectomy can do the same thing. A woman might be embarrassed. Then many times women with breast cancer will also end up with a oophorectomy or hysterectomy or both, especially if they have the BRCA gene. And once you take a woman's ovaries out, all of her estrogen, not all, a large percentage of her estrogen is removed, and a large percentage of her testosterone is also removed. And testosterone plays a big role in sex drive. So a breast cancer survivor goes through a lot of loss of that sexual self-esteem. So how do we treat that? What do? We want to love the parts that we have. So what I tell my breast cancer patients is that you still have a clitoris, you still have a vagina, and your clitoris is a very important sex organ. The clitoris is analogous to the penis in a male. And the vagina, if you think about it, the vagina, although very pleasurable, is also a route to the uterus for sperm and a route for a baby to come out. But really, your most sensitive spot is the clitoris. And as a woman, you still have a clitoris and a vagina if you've had surgery to your breasts and removal of the uterus and ovaries. And so that's important, to make yourself a priority, feel good about yourself, and love the parts that you have. Dyspareunia is a big deal, especially in breast and GYN cancers. And we always think, oh, you can't use hormones, so forget about it. There's nothing you can do. And that's absolutely not true at all. There are many things you can do. So I recommend lubricants and moisturizers. So I recommend silicone-based lubricants or olive oil like you have in your kitchen. Both of those work very well, and there's many of them on the market. And for moisturizer, there are many moisturizers, vaginal moisturizers on the market, or you can use things like Crisco or coconut oil. And just like when you wash your hands at the sink, you put lotion on your hands to keep them from getting dry, you can use moisturizers to moisturize the vagina. And I usually have women use coconut oil twice a day, put some on their finger, put it at the introitus, and some inside. And for some women, that's all they need to keep the tissue moist. You can decide to use local hormones in certain instances, local estrogens, local intravaginal DHEA, and I'll get to that in a minute because you really have to look at the risks and benefits. There's also a procedure now, vaginal laser, that has been shown in studies to break down old collagen and elastin, and your body builds new collagen and elastin, and more blood flow goes to the vaginal area. And this is a treatment for that vaginal dryness due to a lack of hormones, or vaginal dryness, vaginal atrophy, which is now called genitourinary syndrome of menopause, DSM. The vaginal laser will treat that by stimulating your body to create new, healthier tissue and bringing more blood flow. And blood flow is necessary for good lubrication as well. If a woman has a shortened vagina, maybe from a radical hysterectomy due to cervical cancer, you can also use dilators to enlarge the vagina. And so you don't want to forget about that. And last but not least, don't forget about incorporating pelvic floor physical therapy into your treatment paradigm. So when women have painful sex, they tend to flex those pelvic floor muscles, and they can't relax them, and that can cause pain. So what does the American College of OBGYN say about using vaginal estrogen in women with a history of estrogen-dependent breast cancer? So they say that you should absolutely exhaust your other treatments before you move to something hormonal. You got to try the lubricants, try the moisturizers before you move to an estrogen treatment. But they do point out that data do not show an increased risk of cancer recurrence among women undergoing treatment for breast cancer or those with a personal history of breast cancer when they use a local vaginal estrogen to relieve their GSM. And NAMS recently came out, the North American Menopause Society, with their recommendations on the use of hormones for breast cancer patients, very similar. And they say women who fail the first-line therapies with severe symptoms and low risk of recurrence may consider local hormonal therapies. And there's a product that actually hasn't hit the market yet, but is being advertised. And I'm really excited about this product. It's called the O-Nut, and it's for women who have deep dyspareunia. And it goes over the penis, over the shaft, and it's basically a vaginal extender. So it helps the males feel as good without having to penetrate as deep. So for women who have a shortened vagina, or they could have a shortened vagina from surgery or from radiation, this may help them in the future. And the last thing I discuss is that orgasm is important to improving HSDD. I talk about this with my patients because many women can feel very sexually satisfied without reaching orgasm. But when you have low drive, I feel that it's all the more important to reach orgasm because when you do, it's euphoria. You get a flood of dopamine to the brain, you feel really good, and you want to have sex again. So what better way to improve drive than to ensure that you reach an orgasm? All right, I'm going to turn to the medicines now that are available for HSDD, and I'm going to start with Flibanserin. So Flibanserin is the first drug approved by the FDA for premenopausal women with HSDD that is causing them personal distress and isn't due to something else. It has been shown to work in postmenopausal women too, but if you use it in postmenopausal, that would be off-label use. It is not a hormone. It's a serotonin agonist-antagonist, and it affects the balance of neurotransmitters in the brain, which play a big role in sex drive. So what Flibanserin does to the neurotransmitters is it increases the dopamine and norepinephrine, and these are pro-sexual or excitatory neurotransmitters, and it decreases the serotonin in the brain. And we know that serotonin can lessen sex drive. And improvements were seen in women's desire scores as measured in various validated questionnaires and numerous studies. It works about 50% of the time, so some women respond to it. We call them responders, some don't. And it takes about 6 to 8 weeks to see an effect. So when I prescribe it for my patients, I make sure to mention that it's not something that happens overnight. And I also mention that it doesn't give you excessive sex drive. It just makes you think more spontaneous sexual thoughts, maybe a little bit more receptive. I want to set expectations. The contraindications to Flibanserin use are alcohol use, hepatic impairment, or being on a medicine that is a moderate or strong cytochrome P450 3A4 inhibitor. With that said, Canada recently approved Flibanserin. It's not Viagra. And they have much looser restrictions on taking it with alcohol, because since Flibanserin was approved in the United States, there have been some other alcohol studies done. Buproprion is another medicine that is used in an off-label manner to improve sex drive. There are a few small studies because buproprion increases norepinephrine and dopamine, and it doesn't have any sexual side effects like Prozac and Zoloft in the SSRI group. It's been shown to improve desire and orgasm. And you see these improvements in depressed and non-depressed patients, which is important because if you were depressed and you had low drive and then you became not depressed and happy, your drive would likely improve just because of the change in your moods. But it works even in non-depressed patients. But what's important to know for your cancer community and cancer population is that it interacts with tamoxifen. So for women with breast cancer on tamoxifen, you can't choose buproprion. Testosterone has also been shown to improve all aspects of sexual response in menopausal women. So this is something that you can consider using in women with non-hormonally dependent cancers. It has been studied in breast cancer patients on aromatase inhibitors, but it's definitely not FDA approved for that. It's not FDA approved for women at all, and there's really not enough data on its safety in women who've had estrogen-dependent breast tumors. Coming soon, and I'm really looking forward to this, is Bremelanotide, and this is a melanocortin receptor agonist that has been shown to increase desire and arousal in both women and men. The phase 3 studies have been completed, so we're just waiting for it to hit the market, hopefully within the next year. And this is a medicine that's going to be used on an as-needed basis as opposed to testosterone, buproprion, and Flibanserin. Those are all to be used daily or on a regular basis. But Bremelanotide will be something that you use when you want to feel amorous. So to sum up, sexual well-being is important to overall quality of life for everyone. And HSDD is common in cancer patients, and there are many things that we can do to treat it that are non-hormonal. We don't want to miss asking about it because it's so important in women's lives. Don't forget to ask and treat. Thank you so much for listening to me today. Please follow, subscribe, and share to my social media. And thank you very much.